Good evening, doctors and all participants. Thank you for being with us again this evening. I'm Dr. Rizin Kusop, the Secretary of APS, Association of Private Practitioners Sabah. Welcome to our free live streaming webinar again, brought to you by our esteemed association. As usual, during the session, if you have questions, please write them down early rather than later, so that our speaker can have time to address them at the end of the talk. Our speaker this evening is Dr. Somasundaram Singaram. We had him before, so he is no stranger to all of us. Let me read some of his CV. Dr. Soma graduated from Madras Medical College in 1988 and obtained his fellowship in 1996 and completed urology subspecialty in 2000. He previously worked in Queen Elizabeth Hospital and joining private hospital in 2001. He has special interest in urology. He has attended and given a lot of talks about urology in various forums. Dr. Soma now is the Senior Consultant Urologist in KPJ Sabah Specialist Center, Kota Kinabalu. The topic he will be delivering today is actually very interesting, both for us, the GPs, as well as for our patient. The title is Erectile Dysfunction. How can you make it functional again? Ladies and gentlemen, Dr. Soma.
Hi. I can. Hi, good evening to everybody. Thanks for the APPS to invite me, and thanks to Risco for the kind of introduction. I'm going to talk about not only erectile dysfunction, also about premature ejaculation. Okay, these are the two common topics. I don't want to talk much about hi-fi stuff. I'm going to talk about the topics. I mean the message will help your practice. Even if you see 100 patients, if you get 50 patients correct, it's more than enough. That's what. How can you improve your practice in your local setting? Okay, especially in Kota Kinabalu. Okay, so now the two topics are erectile dysfunction and premature ejaculation. Okay. Now erectile dysfunction. Let's make it very simple. We talk about simple erectile dysfunction and a complex erectile dysfunction. Complex is even difficult for us to treat. So let's not worry about the complex. Even in your practice, most of the time you will see simple erectile dysfunction, simple problem, which is very easy to treat. You just have to listen to them and easy to treat. Okay, and most of the time in simple erectile dysfunction, it is mainly psychological, a short duration. I can't perform for 2 weeks, I can't perform for 1 month or 1 year or 6 months, that kind of thing. Those people are mostly psychological, and the treatment is very simple. Complex erectile dysfunction, usually older people, multiple medical issues. Any medical issue, there will be some degree of erectile dysfunction. Any medical issue with a vascular disorder will have more problem, like diabetes, hypertension, ischemic heart disease, and spine injury, pelvic injury, radiation, all this. Those are one difficult for you, difficult for me. Okay, so I would say really difficult. Let's not waste time on that. That's like, it takes a long time to treat. So that's not for the general practitioners. How to say, on the scope of treatment. So we are talking about simple for you all. Okay, then last one is hormone deficiency in complex, that maybe all of us can treat. General practitioner treat, and we can also treat. So again, I recap: simple problem and complex. Okay, that's two issues. Identify when the patient walks in, is it simple or complex? That's all. Okay, so again, next step is, once a patient comes to office, how I manage. I'm going to tell you, I'm not going to give you textbook description. I'm going to how I manage. Okay, once a patient walks in my office, I know it's a simple young man, a simple problem, or a chronic problem, so I know how to play the game. Okay, now next line is history. Again, how long, short duration, long duration. Okay, Then early morning erection. When I ask history, I ask them one simple question you can ask all your patients: do you have early morning erection or not? If he says, I have early morning erection the last 1 week or 2 weeks or 3 weeks, I have once in a while I like out a morning wood, that means you're comfortable to treat him, because it's very simple, it's considered simple and easy to treat. If the patient doesn't have early morning erection, langsung tada, then that is a different ball game. So I only ask my patient only one question: early morning erection, ada ka tada? Ada means that means you're game on. You can treat the patient, okay? Then examination. Examination is very important. Normally we think erectile dysfunction only examine, because just a nice nice man walks into you with a beard and all that, good, like macho looking and all that. You still need examination, you still need examination, I'll come back to that later. Then investigation. Investigation also, now investigation, last time we used to think, oh, no need investigation. Now you need investigation, like you want to know whether you're diabetic, thyroid function is normal, hormone is normal, all that kind of thing normal, kind of, now and then we have pitfalls, and we think it's normal. Oh, macho man suddenly finds the testosterone only 4.5, So basic investigation is really necessary, because the treatment is going to be long term, okay? Now next, the treatment, okay? These are the 4 arms, I've already touched a little bit about it. So okay, again back to history. I've already told earlier, to recap the thing. History: early morning erection, morning wood, ada ka tada, in the last 3 weeks or 2 weeks or 4 weeks. They say yes, it's good news for you, because it's easy to treat, okay? Then of course you got to go through all the medications what he's taking, metoprolol, some of them cause ED and all that. And then you can talk to the physicians and try to change the medication if you feel like. You listen to the patient and say, after starting this medicine, my thing going down. So then Google and see this medicine causes a problem or not. If it causes a problem, then talk to the physician or whoever is doctor and say maybe can change or not. And then number 3 is alcohol. Alcohol, 1 or 2 pegs makes you good, but the more makes you go down. So if somebody's got erectile dysfunction and is taking a lot of alcohol, then you just have to ask them to stop. No point, I want to have alcohol, then I would have sex. No, alcohol gives you desire, but you just can't perform. Okay, alcohol gives you desire, but at the end of the day you can't perform. That's alcohol. Drugs also the same. Then the stress and the workload. Say for example, I was just the stress and the workload. Like for example, if you're googling playing video games till now, we have a new problem. I have a couples come and tell they play video games till 1, 2 midnight, then they can't perform. Sure, you can't perform. I mean, if you're playing video games till 2 midnight, then that's an issue. You got to address that stress and the workload. Okay, these are small history taking. The small things you can tell them to have a better quality of life, or how to say, change your habit. Stop alcohol, stop drugs, stress, and games and video, Google, WhatsApp, and all the kind of thing. Maybe that smaller things which can help. Lifestyle changes. That's what you're talking about history. Okay, lifestyle changes. That's basic. Anywhere lifestyle changes. Okay. Then once you've done a history taking, you have found the lifestyle is complicated and all the kind of thing, then you go to general examination. You go to general is generally, is he obese? Is he a bit, other disease what you suspect from him, general, I mean, just courtesy, just about 5 minutes to examine him, So then genital examination, absolutely important. I've seen in my own practice over and over. Open the trousers and see suddenly small testicle. Open the trousers and see suddenly the penis got phimosis, I've had phimosis in engineers, accountants, doctors, and all the kind of thing. Phimosis, phimosis, penile phimosis, So, and of course, you have sex that got pain, it causes pain and erectile dysfunction. So you have to, once you remove side, you have to treat a do a circumcision, help that a little bit. Small things. Once you know the testis is small, testis is small, maybe then the hormone is abnormal, then you do a hormone test, then you're in a different direction, So those are the ones we are trying to tell you, So examination is basic, history, examination, okay, basic, testis is normal or not. Suddenly you find he's got a cordie, when you examine, he's got a cordie, he's got a phimosis, he's got a small testis, a lot of things, so you have to understand that, So examination is, a simple examination is really important, okay? Going backwards. Okay, once you've done the history taking, examination, genitals is absolutely normal, good size testis, penis is normal, no abnormality, all that kind of thing, then you go investigation. I was just talking to Risco. Those days we were saying, young men no need investigation. 35 mostly normal, ways of investigation. Now no such thing. You see young fellas also, they got diabetic, they got low testosterone, this and that. PSA is only for older people. If somebody is like 60 years old man, ED, of course you got to add a PSA to make sure he's doesn't have a prostate cancer. Not for young people. Young people, please don't do PSA. I've told the last talk also. No PSA for less than 40. You are going to create you're going to open a chapter of trouble for him. Okay, no PSA for less than 40. So coming back to general blood tests, like why do general blood tests? I want to see whether it's diabetic or not, his thyroid function is normal or not. Okay, then of course his testosterone is normal or not. Okay, those are the ones I want to know, and hemoglobin and rest, simple tests. And nowadays blood tests are a little bit very cheap, so I like to do the blood test for everybody. Okay, because I don't want to treat somebody without the full information and suddenly be caught with my pants down and say, oh, testosterone was low from the start, from 4.5 kind of thing. So I'll do just this basic blood test, testosterone and PSA for older people. Okay, coming back. So now we have done the history taking, we have done the examination, we have done the blood test and everything, and it's perfectly normal. And most of the young people are, generally speaking, they are normal. Okay, generally speaking, I do all this tests also. Most people, my finding is most people I would say are normal, but I still do. Okay, because they pay a lot to come and see me. I make sure I don't miss anything. Okay, I do all that, and I'm clear from the start. Okay, so once I've done that, now treatment. Coming to ED, simple ED is very, very easy to treat. Give one of the what's his name? One of the Cialis, they got PD5 inhibitors, PD5 inhibitors. Simple PD5 inhibitors. How do I treat? You can give any PD5 inhibitors for this kind of people, and Zoloft. Let me tell you how I treat. A young man comes to me, erectile dysfunction. I give him 5 mg Cialis every day. 5 mg Cialis. I'm not promoting Cialis. I'm just saying that is one easy to communicate. Cialis, Tadalafil. 5 mg daily. I always, because most of these people have a little bit of premature ejaculation on top of that, or a bit of anxiety on top of that, performance anxiety. So cut down the performance anxiety. I add 25 mg Zoloft or 50 mg Zoloft. So if the patient sits in front of me, I tell him, you take Cialis 5 mg in the morning and Zoloft. This is an SSRI. Any Zoloft you can give, paroxetine, dopoxetine, Zoloft, sertraline, anything like that, any SSRI. But I started with Zoloft and I like it and I just stick to it. It's quite easy. So 25 to 50 mg. Okay, so I normally first time we sit, I 5 mg Cialis and 25 mg Zoloft in the morning every day for 1 month. They are really, really happy after that. Once they're happy, then they always ask this question, should I continue for long term? Yes, you continue for long term, but you can play with it. You take 2 times a week or 3 times a week, on demand. Okay, something like that. Sometimes I say if 25 mg Zoloft doesn't help you, jack up to 50 mg Zoloft. There's one tablet is 50 mg. Sertraline. Sertraline. Chemical name is sertraline. So I add this both together, Cialis and Sting. And I would say most people are okay. This we are talking about psychological ED, short duration, old or young doesn't matter. Short duration. This is a good drug for them. Okay. Of course, if the hormone is low, that's a different story. So I recap: simple ED, you can even give Viagra 50 mg half or generic Viagra 50 mg half every other day, daily. You can play with it. I normally give them daily for 1 month and ask them to get the confidence back. Once they get the confidence back, they say, oh, doctor, thank you very much, I'm very happy. Now what should I do long term? Okay, you can cut down 2 times a week, 3 times a week, play with it. Okay, then they will slowly know that trick. And then they don't, my patient don't come and see me after once or twice. They go to the pharmacy and buy, and I know I'm signing for the drug. When the pharmacy sends a prescription to me, I sign for them. I know this patient on this patient on that. So I don't ask them to come and see me every month. So the complex ED is a different story. Older people with multiple medical issues, they don't have they don't have early morning erection at all for many months. Those are the ones absolutely difficult to treat, So what I do with them is I give them as original Viagra 100 milligram, it's expensive. I give them, sometimes I add a bit of Zoloft 25 milligram to that. Then I see. I also check the hormones. If it's low, I add some hormone. A hormone treatment is a different story. Again, going one step backwards, ED got two parts, One is I can't have erection. One is I don't have desire. You don't have desire, you cannot do anything about it, I say, like for example, I'd rather go to a mountain and do walking than have sex. I don't have desire to have sex, That one you just can't treat. End of story, Desire has to come from inside, you cannot give desire to the person, Okay, that desire has to come from inside. And if you check the hormones, normally most people are low, normal. Some people are low. If they're low, they can give a had hormone. Hormone treatment again falls into two groups, hormone. I'm talking slightly deviating here. I'm talking about hormone, Hormone is associated with desire. Okay, somebody doesn't have a desire, just check the hormone, If the hormone is normal, then still doesn't desire, then too bad. You can't do anything about it, Maybe he doesn't have desire. Maybe he's not interested in girls, Maybe something else is wrong with him, So for that matter, no matter whether you give hormone, whether you give Viagra, whether you give counseling, nothing is going to work, It has to come from inside. Okay, that's what. So desire. So coming back to hormones, if the hormones are low, then the two ways I treat. I give Nebido injection, but that's very expensive, about $700 a month or $800 injection, which lasts about 3 to 4 months. Number two, in our hospital we have this testosterone gel. We ask them to apply every day. Once they apply every day, they get a bit of energy, they get to feel good. Then ask them to run in the sun half an hour. The sun also converts the fat into testosterone, and the testosterone will pick up. And if it's testosterone in our lab is about 9 to 27, I like to keep it 14. If it's about 14, 15, I'm quite happy with that. Serum testosterone 9 to 27 is our lab, different number. 9 to 27, mine is about 13, 14, I'm quite happy with that. So I give them testosterone gel to apply every morning. You can find, and it's called and testosterone gel in the hospital. You just cut the thing and apply. So apply on your body, all the shoulder except the breasts and genitals everywhere, and wait for 5 minutes to dry. Then put your baju, then go on. I do ask them to do for a few months. It's expensive also, at about 300 ringgit per month if I'm not mistaken. So you can do 2 times a day or daily. Testosterone gel plus your Viagra plus your Zoloft plus your Cialis, something like that, on and off. Those are the ones I try for complex ED and with hormone deficiency. Okay. So again, recap, simple. If you want take home message, 5 milligram Cialis and 25 milligrams Zoloft, give everybody, and just call me after 1 month and say does it work or not. Okay. 5 milligram Cialis daily. If you can't, Cialis is expensive, then you can get the generic one. Last week on India, some company, not Indian, company from KL came and gave me the generic Cialis 20 milligram, Tadafil, I forgot the name, Also you can take the 20 milligram, break it to half. You can take alternate days, also good. Cheaper, because this sexual treatment is expensive. Okay, so we need to consider the cost also. You can take the generic, any generic also break into, say like for example, you got 100 milligram generic Viagra. You break into half a quarter and take every day. No harm. It's about $10 and you break into 3 pieces or 4 pieces and take every day. 25 milligram plus your Zoloft also help you. If it doesn't help, so sex is expensive. So this is how I treat. Recap: so Cialis, Zoloft. That's all. Okay. So this is about erectile dysfunction. I want to recap the treatment again. Cialis, Zoloft and hormone if hormone is low. Not simply bang hormone with the hormone is normal, I remember those days when ED we straight away give one sustained injection many years ago without even checking the testosterone, That's wrong. Check the testosterone level and tell him that is not the correct answer. Hormone is, if it is normal and you go give a jab on top of that, that's abnormal, Then you cut off his normal function. Then you give 2-3 jabs, his normal testosterone will stop producing testosterone, then you will be dependent on the external source. So you're creating a new problem without a test. So no testosterone injection without a valid reason, Okay. Now that's about it. Thank you. So ED is over. So we still got how many minutes? Over 10 minutes. So now the most important topic: premature ejaculation. Okay. 30% of the men you must again, premature ejaculation has got two groups, One is a early onset, from small they are like that. One is a late onset again. So recap, I'm telling you, 30% of the men from young will have, 1 in 3 men will have some form of premature ejaculation, okay? And from those days they know where to go. They just learn to live with it, and tahan, okay? That's the premature ejaculation. What is premature ejaculation is, by definition, even before the partner is stimulated, aroused, you already ejaculated, That is called premature ejaculation. Less than a minute or less than maybe a few seconds, pop, 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 it comes out. The woman is not even warmed up, That is called premature ejaculation. And the couple will be stressed out over time, okay? That is called premature ejaculation, okay? So early onset, beautiful treatment. Late onset, you're worried about. Say, for example, I'm a 50 years old man, and recently only I got a premature ejaculation. That means something is different, Earlier I didn't have, now. So that is a different story. If it's a late onset, okay, you just have to investigate a little bit, same like any normal man. Examine him, history taking, blood test, ultrasound, okay, rectal examination, ultrasound to see if he's got bladder stone or bladder cancer and all that, rectal examination to see whether he got prostatitis, okay, or prostate cancer, okay, those are the ones, simple examination, no big deal, simple examination, then everything is normal, PSA is normal, the infection marker is normal, diabetes is normal, he doesn't have any sexually transmitted disease or VDRL and HIV, all the kind of thing is normal, then the treatment. That's simple, like anybody, late onset, you have to be worried. From small, most of premature, actually, we see the young people, 30s to 25s to 30 to 40, wow, doctor, sikijap keluar, you. So what happens once is he has premature ejaculation, then he has anxiety. Then once he has anxiety, then he got performance ED, because even before he starts, he's going to know he's going to have premature ejaculation, he's going to tahan or not, then he'll be worried, then his erection will go. It's called anxiety performance, okay? So all this will look like a knock-on effect is going to have it, okay? So now once you got the premature ejaculation understood, you must ask, people come and say, to come to my clinic and say I got ED, then ask more questions, then they'll say it's a premature ejaculation. Actually, it's not ED, they mix it up. They can't tell you correctly it is PE, then ding dong, then say, oh, I mani keluar cepat. Then tidak tahan lama. They simply say in simple words, tidak tahan lama. Tidak tahan lama means we think it's ED. It's actually not ED. Tidak tahan lama means like premature ejaculation. So, like chit chat for a while, then you find out the answer. Again, back, same simple examination. General examination. Anybody must examine, For you examine something, you get up something else, So suddenly find a big testicle, suddenly find a hydrocele, suddenly find a phimosis, suddenly find a small testis, suddenly find an undescended testis, All this is a window of opportunity to tell the patient, okay, this all is there, you better take care, So examination, simple examination, just about 5-10 minutes only, My clinic about 10 minutes at the most, Okay, so history examination similar to ED, okay. Then again, how do I treat? Now the reverse. PE, erectile dysfunction, I gave Cialis to the first and Zoloft the second together. In this premature ejaculation, I give the Zoloft. SSRI is the number 1 drug. If they say my erection is absolutely normal, I no need Cialis and all that, okay, fine. I then just give them SSRI. How do I learn this? In our urology training, last time, many years ago when I was training, these were not important, they didn't pay much attention that time, and we didn't have Viagra that time, and the ED clinic was a pain those days, so we didn't know that. Then I remember Professor Khalid came from KL and gave a talk 20 years ago, he told me this trick, he adds SSRI to all his patients, and the SSRI came out, even how the SSRI came out in the picture was the psychiatric patient, anxiety and depression patient who get SSRI, they complain. Once we take the medicine for long, we get delayed ejaculation, we cannot ejaculate, If you ask the psychiatric, the people who are taking this medicine for psychiatric issues, they say ejaculation is sangat susah. So from there we extrapolated and we can give for our premature ejaculation patients, So that's when it started, and that's when it just sidetracked, and now it's a treatment for PE. And they had a specific drug only for PE called Priligardi, if I'm not mistaken. It came many years ago, then it was very expensive, then it didn't take off the market, 30 and 60 milligram. So it didn't take off the market. I don't know, because they're very expensive. It came at $50 one piece, and $50 one piece. And here Zoloft is 5 ringgit one piece. So which has the same function, so might as well give this one up. So I give coming back to premature ejaculation. If you have premature ejaculation in your clinic, he comes to you, you give him sertraline or any SSRI. You can Google paroxetine, dapagliflozin or something. So many things are there. You can any SSRI, but I just like to stick to this drug. It's quite useful for me, and it's available in our pharmacy. So our pharmacy doesn't have all the SSRI. This is one good drug, cheap, 5 ringgit. So it's available in the pharmacy. I give to my patient Zoloft. I give them 50 or 25 milligram. 50 milligrams, suddenly if you give the first dose, it gives a bit of strong nausea and vomiting. So sometimes I give 25 milligram for a month, then jack up to 50 milligram. So what you can do is, if the patient comes to you, any SSRI, small dose, half dose, regularly for 1 month in the morning. I ask them to take it in the morning because it takes 6 hours to work, So I take them after breakfast, good breakfast take, because it gives a bit nausea, vomiting. Maybe some people say can't sleep, some people say edgy, some people say bowel motion a bit more, small things, I say that's a small price to pay for premature ejaculation. You just have to take it, So 25 to 50 milligram on the morning daily. If they're happy, once you get okay, this medicine is giving some effect, then I ask them to take alternate days, or then after the alternate days, sometimes I ask them to take. Of course, you need some planning, You need some planning. Weekend you take, when you're going to take a holiday you take, or you take in the morning of you're going to have sex, you take. But of course, you take in the morning, then end up fighting in the evening with your wife, then that's the end of story. Fighting and gone down the drain, then forget about it. Okay, that's okay, fine. So those are the ones I say. So always have this SSRI as a backup. Then if you find SSRI alone is not helpful, then you can add a 5 milligram Cialis or 50 milligram Viagra. Generic, anything, PD5 inhibitors, anything small dose you can add on top of the thing. Sometimes I tell the patient take both together. Seriously, all the doctors also can try both together in the morning, then you see. So it just really helps, So it cuts the anxiety off, cuts the performance anxiety off, delays ejaculation, that kind of thing. Sometimes if it still can't work, I ask them to take 2 days, one day before and one day on. So 2 days, SSRI. We're talking about premature ejaculation only, SSRI 2 days, one day before. So then the patient says, oh, I'm going to lose my spontaneity. Too bad, that this is the treatment. This is how it works, You want then they always ask, can I go back to normal? Can I try natural and all that? I say, you try the medicine, works fine. You have the medicine as a backup. Then you try all the natural therapy. If your natural therapy helps, fine. If it doesn't help, always you can fall back on the medication. So you can play with it. It's not like you must take. But most of the people in my practice, I see they come and buy. They come and buy all the time. They come and buy. Because I sign the prescription. So I see them. So this is how I see it. SSRI, definitely. Those days in premature ejaculation, they used to give, stop, start technique, analgesic on the glans penis, condom, psychology counseling, blah blah and all that. Those all pure waste of time. Now, simple SSRI, PD5, any combination you like, small dose, big dose. Okay, you can try anything you like. Okay, generic also is fine. I'm just saying Cialis and Zoloft. This one a name I know regularly. It's basically comes to sertraline and all the tadalafil, sildenafil, vadafil, all the fills. All the fills are the Viagra, the group, PD5 group. Anything to fill in, I think it will has been good. Okay. So recap: SSRI, Cialis. SSRI, Cialis. You try that, and if it doesn't work, let me know. Okay. So happy New Year. I've finished 30 minutes. I think question. 45 minutes I should finish, is it? I think enough already.
Yeah.
Uh,
We'll.
this is it. There's nothing much to talk about it. Basically, it's like, it's still on, you know? Is it still on? It's simple, you know. Examine history taking, early morning erection is okay or not. Early morning erection, then you're on a good track. Early morning langsung tarik, then you're on a bad track, you know. That these two medication, and standard question is, can I come back to normal? Well, you can come back to normal, you know. You can always try, you know.
Thank you, Dr. Soma, for that very informative and interesting topic. I certainly learned a lot. We will wait for a while for a question coming in. There are no questions at the moment. I have read about the small doses of Cialis in the past, quite sometimes only the 5 milligram. Is it easily available now?
It's very, very easily available.
Yeah, I've actually ordered to one of the supplier recently. No, not recently, probably about 2-3 years ago. They haven't got it yet.
Oh, no.
So now it's quite easy.
Easy.
Okay, excellent.
Now it's easy. 5 milligram. You know, 5 milligram Cialis earlier, it's not that it was not available. I personally feel it was very expensive, you know, because in our hospital, I work at KPJ, Sabah Specialist Hospital. It's about 13 to 15 or 16 bucks around there, one piece of tablet, you know.
Yeah.
So if I say 13 times 28, it's about 300 bucks, you know, around there, for a month. So it's expensive. So earlier when it came, I also in my own hospital, I did not promote it. I did not promote it, rather I did not push it very much, you know. Then I found people from KL, here, Singapore, everywhere bringing the drug and showing me, you know. And then I said, wow, if they can get from there, why can't we do it here? Then might as well do it here. Now it's running like hotcake, you know.
Yeah.
So I say, I give them 30 tablets, everybody, without any questions, they buy, you know. So sometimes we think for patient that patient can't afford, and we try to tailor the treatment for them. Actually, patient can afford. So 300 bucks, like some people like kacang putih, they buy, you know. So now it's available, you know. So once we how GPs start promoting a bit more, or anybody promoting more, then the vendor will stock it and supply. If nobody is promoting, the vendor holds also no use now. So it's very easily available. Now generic Viagra, generic Cialis, generic, you know, original Cialis, everything is easily available, you know, easily available. And we might be thinking it's very expensive, but it will surprise people are willing to buy even for BPH, you know. Now the Cialis 5 milligram is used for BPH also, for low urinary tract symptoms. So mild low urinary tract symptoms with ED, they will give Cialis 5 milligram. It helps the low urinary tract symptoms plus the ED, 2 in 1. Okay, bye.
Yeah, I also been teaching patients to split the Cialis actually to half or even quarter or a third. But you know, because of the shape is actually oblong, it's actually quite difficult to split it nicely. But now that it comes with 5 milligram.
Oh, the 20 milligram, is it?
Oh, yeah, the 20 milligram.
20 milligram.
Now it comes with 5
now
milligram.
5 milligrams you can easily order, you know. 20 milligram Eli Lilly, if I'm not mistaken. You can easily get 20 milligram. I mean, yeah, you can cut it in 2 also.
And are you worried about their cardiac status? Or
nothing. Nothing.
Or
Even the IGN people give.
Okay.
Even the IGN people give. I don't know. Unless they're taking sublingual GTN, then we don't ask them to together. But then otherwise nothing much. Of course, the side effect is 5 milligram doesn't cause any problem. Only the 100 milligram and the 20 milligram cause a little bit of headache. The blue become grey. You know, color vision problem, headache, nose block. You know, once you eat and only within 1 hour you can get nose block. Then the bloodstream, it's already in the bloodstream already, you know. So those are the small things, but 5 milligram nothing. 5 milligram nothing.
Sure. Okay. Now, Dr. Soma, you mentioned about this medical treatment, but could you explain a little bit about devices and stuff that
exactly.
you could use for your ED?
This is my last slide. So devices are
devices or injectable.
Next slide. So I've one more here. Next one. Okay. Next, this is the last thing. I mean, medical treatment is a common one now. Okay. Then after that, if say, for example, now you're talking about serious, complex issue, complex problem now. We tried Viagra 100 milligram, original Viagra, the hormones are normal, everything is normal, but zero erection, and he's probably got a young wife or something like that. Then that's a different ball game. That's when we try to give them injection. Last time we used to have this. No, I don't know whether it's still available or not, because any drug which is not widely used, after that the company close shop, because it's not moving. So we have this injection called alprosterol. So whereby it's the same PD5, the earlier one, the first version one. It comes in a small bottle with the powder, the water, the injection, the syringe needle, everything it's like a shaving kit. So open, put the water into the bottle, shake the injection, and just make it like a small syringe. Everything is there, ready-made kit. Then inject into the penis directly, just about 20 minutes before sex. Then immediately you have a hard on. Then you can use that. So that's one thing. But I used to give in my hospital. But I tell you, most of them after 1 or 2 injections they just panic and they stop. So to such an extent, we don't order. After some time, pharmacy did not order, then they pay first, then we order. So after that also stopped already. So that's called injecting, just like a diabetic injection. You just inject into the penis and cause erection. That is one, injecting into the penis one. Number two, that I don't know if it's still popular or not, but at least it's not available in a hospital in OKK. We can order. Number two, last time we used Muse, M-U-S-E. Muse is inject same PD5, like a Viagra kind of combination, into the meatus of the penis. Small like a pen, small like a bullet. Just put the penis and roll the penis like a sausage. Then people used to complain they got irritation, urethritis, burning sensation, this, that also did not take off very well. It was available for a while. Why I'm saying this? If it's a good drug, it will stay in the market. For example, Viagra is a good drug. It is there in the market for the last 20 years, or 1996 onwards, about 25 years in the market, So it's a good drug. So you don't need promotion. It'll self-promote by itself after some time, because it's good. Cialis is good. It'll self-promote. Cialis 5 milligram is good. It'll self-promote after some time. Okay. So this one, the Muse did not. Then after that, I didn't forget to put one. Number 3 is vacuum device. They used to wear vacuum device. I personally, it's a very cumbersome thing. It's just a vacuum, put the penis and suck, make the penis larger, then put a rubber band in the base of the penis. It's called a vacuum device. It is not cheap. It's 5,000 plus. Then if you buy one and it's not useful, you can't do anything. You can't give it to your friend for that. So you're stuck with the $5,000 ringgit device. A vacuum device, I think it's cumbersome. People have tried that. You can buy online. I've seen my own patients, buy online and come and show me that, So I say, if it's useful to you, then go ahead with it. If it's not useful, what can I do? So they've tried that also. Then of course we have the implant, the tooth implants, which is very common. And when I was in the UK in 1999, every week you used to have this malleable penile and inflated penile implant operation. Every week, 1 or 2 cases. I was saying, wow, it's two, like, I don't have a picture here. You can Google and see basically two rods, rubber rods put into the penis, into the corpora, and that's it, closed. Very simple operation. Then if you want, you make it harder. If somebody wants it, makes it harder, erect it. Then if you don't want, bend it, just a malleable, just like a foldable scale, foldable scale. You kind of bend it. You can Google and see, malleable implant. Then inflatable implants got technical, is very expensive, 20,000-30,000 bucks. You got 3 chambers. You can put a balloon. It's got a balloon. You press a button, the balloon will go up. Then you press a button, the balloon will go down. Here right now, I was told in hospital Kuala Lumpur they do. Apparently, one of the surgeons is quite interested in that. In a couple of private hospitals in Kuala Lumpur they do. And it's quite expensive. It's doable, malleable implant and inflatable implant. Inflatable implant means if inflatable implant doesn't work, you got to rechange it after 5 years or 7 years. It leaks or something like that. Just like a tire,
Yeah.
No, it doesn't work. If the valve doesn't work, you could reset the whole thing. I don't know. And those are the ones. If you ask me a question, is it commonly done in Malaysia? I'm not sure. But when I worked in the UK in Bristol, it was done commonly. If it's commonly done, they know the complication and they know how to change it. Those are ones. But coming to for you, this one you can tell your patient if you want all this, nothing is working, go to Kerala, get a malleable implant or inflatable implant. If all is not working.
Not available in Sabah.
Not available in Sabah. For sure, at least for now, I can confidently tell not available in Sabah.
Okay.
But we can bring guys and do it here. But doing is one thing, and following up is the biggest problem.
All right. Thank you, Dr. Soma, for that explanation. We got a few questions here. Number one from Muhammad Nazri Muhammad Daun. Hi, Mr. Soma. Do you recommend CVS assessment prior to PDE5 inhibitor?
What is that?
Cardiovascular
No.
assessment.
I just 5 milligrams. 5 milligrams Cialis, no need anything. Okay. Of course. I mean, he's got a good question. Last time, even now also, if you have ED, recent onset ED in elderly, we are talking about two groups. Younger people, no assessment, nothing. Older people, if they have ED, I mean, he's got a question. Older people, if they have a recent onset of ED, they say is a window of opportunity to check the coronaries. It's a window of opportunity because the blood vessels in the penis is small, so therefore the blood vessel in the heart also can be small. At some sclerosis, atherosclerosis there. So it's a window of opportunity to have a checkup. Well, I mean, if the patient wants it, can. Sure. But I don't say, if for example a man comes with ED to me, I don't say first go get a cardiac assessment, then come and see me. I don't say that. But if he wants, you can tell him, no harm in seeing. Of course, then again boils back to you check his cholesterol, history, hypertension, diabetes, blah blah and all that. If everything is having, then he's got a risk factor of coronary vascular disease, then no harm in sending to cardiac team to have a. Then he's going to, from ED he's going to get another headache.
Sure.
But the question is correct. ED is a window of opportunity to check the heart.
True. Alright, I think you've just answered the second question also. From Amirul Salihuddin Manan. Erectile dysfunction is associated with heart disease. If patient presented to us with ED, should we always arrange for heart assessments such as ECG, stress test for the patient? I think from the point of view of GP, I think he's asking on behalf of GP.
Yeah,
as
exactly.
A GP, do you do that before?
Yeah,
you
exactly.
CRS?
I mean, it's a good question, but I mean, he just simply comes for ED, then suddenly you start a big chapter. Suddenly goes cardiac assessment, then he gets angiogram, then he gets a stent, then he gets all that. I mean, that's what we were being told before also. ED is a window of opportunity to have a cardiac assessment. How far you want to go in the track, it depends on the comorbid condition. Say for example, you've got a 50 years old man, he's got diabetes, he's got hypertension, he's got a sedentary life, his cholesterol is more than high, he's got a family history of heart attack and all that. Then you can say maybe all this is there, why don't you have a cardiac assessment before you start ED treatment? Maybe no harm. Yeah. But will I send everybody coming to my clinic to cardiac assessment? Then all the ED fellows have to go to have cardiac assessment. This for older people. You may divide two groups. The older and the younger. The younger ones no need anything. Cialis and Viagra. I mean Cialis and SSRI. Younger fellows we're talking about, which you're going to see about 50-60%. Older people, I think it's okay, but
opportunity.
It's a window of opportunity. Yes, it is definitely a window. Yes, I agree with you, but I don't see that problem because most of my patients already have the assessment.
Okay.
Already have all the assessment before they come and see me. So I don't need to send them to cardiologist. Cardiologist is sent to me. So it's reverse for me. But in your case, I think you can tell your patient you never had any checkup. You have all this problem, comorbid condition as I said, diabetes, hypertension, medication, sedentary life, cholesterol high and all that. So boleh ke kamu pergi check? I think it's quite a reasonable option.
Definitely.
I think it's very good also.
Yeah. I think the question number 3 also asking the same thing. Probably it's already answered, but I'll just read it here. If so, then how much do you go for that? Just resting ECG or require ESD, especially those with chronic diseases?
Which one is it, Mohammed?
resting ECG.
Same.
I think
do.
he's asking what kind of.
Same thing.
investigation.
ECG. Well, if you're doing a cardiac assessment now, I mean, the ECG is no. I mean, in a hospital, we have so many times the ECG is normal and they still have a abdominal. I think I have a personal. I don't know much about cardiology. I think stress test will be the probably closer to better, closer to nothing,
So again, I think
Resting
it
ECG
depends.
most of the time is normal. Resting ECG most of the time is normal. I think it's a waste of time,
Okay.
I mean, because in our own practice, we have seen ECG is normal. When you run, that's when the whole thing goes wrong. Stress test, I would say stress test.
Yeah, I think it's really depend on the patient history and their
Exactly.
comorbidities and all that. Yeah.
Exactly.
We make the decision from
Yeah.
there.
Because it's all about money, You can send anywhere you like, but can you afford?
Exactly. True.
It's all about money.
In fact, most of them will come and they want something right there and then.
Exactly.
And then you tell them, okay, I'll give you this, but you have to come back and you need to do this and this.
Sweet and short.
To continue with this
Yeah,
treatment and
exactly.
stuff. Yeah. That's
Coming back
my
to the ECG,
experience.
I personally think among all I can ask cardiologists, stress ECG will be stress test. Treadmill will be stress test will be the best thing.
Alright.
Closer to best I think so.
Okay. Alright, the
Next
next question is from Dayang Masita. Thank you for very much interesting talk, Mr. Soma. If serum testosterone is low and patient is using testosterone gel, when will you repeat the testosterone level again?
Yeah, first I will give testosterone gel daily, then of course correct all the other conditions and make sure he runs, in the hot sun. Exercise in the hot sun half an hour, mandatory, and get the energy going up. Once he goes up, then when he comes to clinic, he's a Chinese man become brownish man already. That means he's running the sun, He simply says I'm running the sun. It's not because I see the color. I mean, I know he's running the sun and all that. So when I check the hormone about 3 months down the line, 3 months down the line, and if as I told you, our reading is about KPG reading is 9 to 27. If it comes to about 10, 12 or 12 or 14, I'll be very happy. 14, I'll be very happy. So 3 months, I will check. Gel, exercise, 3 months. 3 months, 3 months. In 3 months, even it comes to 12 or 10, and he feels well, he feels well, good in himself, then I'll leave it like that, because the testosterone gel is A, expensive, and B, it's a long-term treatment, okay? So if it really goes up, nicely goes up, then if he wants to cut down, then okay, fine, we can stop also, I can stop. Then I'll check maybe 3 months, if it's hovering around 12, then his erection is good and he feels good in himself and energetic. He's not sleeping in front of the TV. He can energetic, he can, hormone makes you energetic. You don't sleep, you don't get lethargic very easily and all that. He feels good, then I'll leave like that. Then running will take care of himself.
Exercise.
Yeah, exercise, any exercise, swimming, running, anything. No, but not treadmill in the room, in the hot sun.
Under the sun is the keywords there.
Because I like to run in the hot sun.
Alright, we don't have any more questions at the moment. I think the last,
Herbal, you tell last.
the last question from me is, I have read articles and various suggestions from other specialties that this Cialis or PDE5 inhibitor in general also actually helps heart in terms of
Yes.
cardiac
Yes.
function and
Yes.
everything, because the coronary blood vessel is similar to our penile blood vessel and everything. So, would you give in your consultation, would you tell the patient that if you're treating your ED, you in a way looking after your heart as well? I mean, is that kind of fair statement to make when you're consulting your ED
Well, I
patient?
don't say that exactly. I don't say that, but I know it dilates the blood vessel and it lowers the blood pressure and makes them feel well. Feel well, and once you feel well, you're happy. You probably it treats the overall whole patient, in short. But I don't specifically tell that. Maybe I should tell that from now. Whenever I give Cialis, you're treating not only you're treating the whole body,
Yeah,
and the heart.
in fact,
Yeah, cardiologist also.
honestly, I've been saying that, but I'm just wondering whether
It's
that's
good.
actually
It's
out of the way.
No, it's good. It's good. It's actually good. Once the ED is corrected, the patient feels really happy, And of course, medically also it dilates the blood vessel, it also dilates the heart, every blood vessel, So in a way, it lowers the blood pressure a little bit, dilates the vessel a little bit, gives you good well-being, everything together. It's a multi-pronged effect, one drug.
So
You should take it, yeah.
also.
So yeah, you should, you should tell them it's a little pricey, but only thing we don't have generic that drug, but eventually you'll get it now.
The Cialis
5 milligram generic not yet available, but you have generic Cialis. Recently a company came and showed me it's generic Cialis. Why Tadalafil? Let's say Tadalafil, generic Tadalafil, 20 milligram. They told me just last week the 20 milligram, the patient price is $12, okay. 10 to 12 bucks. So make it half, $6.
You just have to learn how to split it.
And that's quite a long tablet, so you can cut it into half. You can take 10 milligram alternate days, also fine.
Yeah.
So, why I'm talking about cost is, if you have a 30-40 years old man, or 50 years old man, he's already on multiple medication. Every medicine is cost. Every medicine is add on money. Of course, the government gives free also. But end of the day, it's cost is very important. We have to just take into consideration. I'm sure we all practice and we know that.
Do we have small doses for Viagra and this Vinadafil also? No.
Viagra last
only
time last time Viagra is only 150, 100 milligram 50. Last time they used to have Viagra 25, 50, 100, and 25 no more. Now they're 50 and 100. But people who have 100 and cut into half, it's also good enough really. But the company says you can't cut into half because the bioavailability is gone, but I just ask them to cut.
Okay. Thank you very much, Dr. Soma. Okay, one more question just came in here from Amirul Salahuddin Manan. Do we always consider erectile dysfunction as a sign of male menopause in older age group? Should we generally tell this male patient that they could be experiencing menopause, andropause?
Yeah. The male menopause is a very, very, very vague term, very vague. There's no clear cut, unlike women, once menstrual cycle stops, boom, they have menopause. That's kind of like the line there. In men, you can't say that. It's not. Male menopause is a vague term, but a fancy term. But if you're really worried about male menopause, you check the testosterone hormone. It's again back to square one. You check the hormone. If the hormone is low, give them testosterone supplement, ask for exercise, then add a Cialis on top of that. Then you treat the male menopause also because of testosterone replacement therapy, and if you've got ED on top of that, add any PD5, any PD5 we like. So male menopause is a bit vague. It's a vague term, but ED is not directly related to male menopause. Male menopause is a different topic whereby you got a man with a fat belly sitting in front of the TV and sleeping. Okay, the TV is on and he's sleeping off. Very 5 minutes, boom, he's gone off. In the car, he's sleeping off. Easily tired, he can't concentrate. That is male menopause. Can't concentrate, sleeping all the time, sitting in front of the TV and sleeping, and lazy, lethargic. Those are called male menopause, where you check the hormone. The hormone is low, then you give hormone. We talk about hormone to make him energetic. Hormone cannot be given every time. We recommend. What people say is not simply give hormone just every day. A is expensive, B is long term. So you give hormone for a while, then ask him to exercise. Once he's getting the engine running, turbo charge already, then you can cut down the hormone slowly. But if he needs it, he needs to take it every day. So what? Every day put one jelly. So that is male menopause. But male menopause is not a clear, but that's not directly to ED. A man sits in front of the TV and sleeps, then he's got male menopause.
All right. Thank you again, Dr. Soma. We don't have any more questions at the moment, and we are running out of time. And before we end this session, I would like to give this opportunity for Dr. Soma again to recap the whole topics about ED and premature ejaculation for today.
Okay. Simple. We are talking about treatable young patients. Treatable young patient. PD5, anything you drug, small dose. As I say again, Cialis daily give them. I would like to give them daily 1 month. Make them strong and turbocharge and make them feel good. Then they will say, "Oh, doctor, this." I've had so many patients come and say, "Oh, doctor, this is too strong and too much. Can I cut down?" Okay, fine, thank you very much, cut down. But if you give slowly, then say, "Oh, I come and see you 2-3 times." So I like to treat aggressively first. Then they themselves come begging to you and say, can I cut down? Very good. 2 times a week, 3 times a week, or PRN. That's it. Combination, SSRI, PD5. Play with it.
Thank
Difficult ones, premature ejaculation, same thing. ED, same thing, SSRI for premature ejaculation, PD5, ED. And it's a combination, reverse combination. So both, keep both together for both of them. So they'll be very, very happy in a small dose, and go up, slightly up. Find the half dose, then go to full dose. They'll be very happy. And then they themselves cut down. Then you tell them, your only 2 choices, you continue long term, you play with it, you have a backup. Then if you're lucky and it naturally become okay, good for you. Okay. The difficult ones, send to urologist. Not to me, not to any urologist you like. It's a difficult problem,
Right.
Difficult one's a difficult problem. I myself find it difficult. I'm sure you will find it even more difficult,
Thank you very much, Dr. Soma. So that's the key advice today. You try to use 5 milligram Cialis and Zoloft. If it still doesn't work, you refer to Dr. Soma and KPJ.
No, not to me. Any urologist, not to me. Okay.
All right, ladies and gentlemen, we are finished for this evening, and we'll be showing the QR code in a while. You have to scan them with your MMA scanner, MMA app scanner, to get your CPD point. And if you have problem getting point from the QR code, please register your name in the registration that we have given earlier in the link, so that we can apply for your CPD manually. Thank you to our secretariat, Ms. Melissa and Mr. Adrian, for their assistance, and we'll see you again in the next talk. Thank you and take care.